Thank you very much for the invitation. I was very excited to come out here. Last time I was at University of Washington was interviewing for residency, which would have been 1995. So I probably interviewed with you, Mike, probably a couple others. But anyway, so I haven't been back since. So very excited to come back. So thank you for having me. I like to talk about the value of the laboratory in a broad sense. So when we think about the value of laboratory testing, the word value is something that we throw about very, very loosely. We have an intuitive sense of what we think value means, but at its simplest, it comes down to what you get out of it divided by what you spent. So for healthcare broadly, you've seen slides like this before. This one was one that I just happened to like the graphic from an old Harvard Business Review. Keep in mind, this is from 2010, so the numbers today are higher than the numbers 3 years ago. But this is one attempt to assess value in healthcare broadly. You take life expectancy on the x-axis and plot it against per capita healthcare expenses on the y-axis, and you put a whole bunch of countries up there and you see where your country of choice happens to land. So if your country of choice happens to be the US, then again, this is no surprise to anyone, but we're way, way outlying with respect to cost and pretty mediocre with respect to life expectancy. Again, this is no surprise. You've seen graphs like this before. Does anyone in the room happen to know if Albert Einstein actually ever said this? Because it always gets attributed to him along with a whole bunch of Yogi Berra quotes. But he may have said this. But the idea being that whatever set of processes, activities, circumstance, whatever that led you into a particular problematic situation, is probably not going to lead you out of it. What was the level of consciousness that led us into this situation where we're not getting a lot of value out of U.S. healthcare? This is where I give you my personal opinion that motivates the talk, which is that that U.S. healthcare has been driven by a technophilic perspective for many decades. This idea that all problems in healthcare can be solved by newer and sexier technology. And by technology, we're talking biologic, chemical, engineering kind of technology, as opposed to say process improvement kinds of things. So. So the corollary to that is just like the rest of healthcare. Whatever led us into our healthcare mess is not going to lead us out. We're going to have to do something differently. And what we've been doing is a very technologic-centric kind of a thing. Who in this room's met George Lundberg? I'm just curious. Anyone? Mike's met George Lundberg. So really interesting guy. He's mostly retired now, but he's one of these guys that's never going to retire until he's over 100 and drops dead of something. I think he's in his 80s. Really interesting guy. He's most known because he was the editor of JAMA for about 20 years. But before that, he was an academic clinical pathologist. Point of trivia, he was the guy that invented critical values. So those of us that deal with critical values, that actually was someone's brainchild at one point, and it turns out it was George Lundberg's in about 1969. And I think he was at UCSD at the time. So basically, this sort of big picture thinker guy who went on to become JAMA editor, and this is something he put in a JAMA editorial toward the end of his career, observing over his many years of experience that there had been this amazing technologic advance in laboratory medicine, and yet we still couldn't figure out how to use the tests appropriately, or we didn't even have a way of measuring whether we were using the tests appropriately. This was 1998. I don't think we're in any different a situation in 2014. So what I'd like to talk about today, just a few little pieces of this. Number one, lay out an argument, fairly high level argument for why more tests are not necessarily better for the patient. And then what can you do about it? So of the what you can do about it, things like diagnostic oversight committees, things like analytics, just a couple informatics things in here, but I'm going to keep it pretty broad level. But it's good to start with a case. This was a case that came to me through a colleague at the University of Utah. I was making some comments about this sort of belief that we have in American healthcare that technology is going to solve all of our problems, but But I was observing that sometimes it's actually counterproductive. And she told me this story, and I found it an interesting story. It has something to do with back pain. I have some knowledge about back pain and back pain therapy. It's not as a provider, because I didn't train in a field that treats back pain. It's as a patient. Back when Jim Aubuchon was my department chair at Dartmouth, I ruptured a disc in my back, and I was out for 2 weeks and went through the whole treatment process. So I'm coming at it from that perspective. But anyway, the story here was the brother of this colleague, young male, probably early 40s-ish, goes to his primary care provider for low back pain. The garden variety complaint happens all the time. This is not an unusual primary care kind of a thing. At the end of the visit, the doc hands him a lab slip. Okay, red flag for a minute. Why are you doing lab testing for a patient with back pain and no other complaints? He didn't know, but he's not a medical expert. I don't know what the guy's profession was, but it wasn't healthcare. And being an obedient patient, as most are, he followed his instructions and he stopped by the draw station on his way out and had his blood drawn. End of story. Now, presumably he was getting some physical therapy. I don't know whether he got imaging. He shouldn't have, but I don't know really what happened to his back pain. The reason I bring up the story, the interesting thing was he gets a call 2 weeks later from Blue Cross. And Blue Cross says, we're processing your claim, and we see that it's supposedly for back pain, so we're wondering what this $5,000 package of lab testing is all about, so we can figure out whether to approve it or not. And he had no idea that that's what was done. He wasn't told what the testing was. He just was told to get his blood drawn. So this is just a weird story, but this actually happens every day in American healthcare. So what seemed to have happened, I don't want to name names and get labs in trouble, but let's just say there's a commercial laboratory here on the West Coast that has these very expensive panels for cardiac risk, and they send salespeople into primary care offices to try to convince them that this is the latest and greatest, and you'd be depriving your patient if you don't give them the latest and greatest, and they end up charging a lot of money for these big panels. But if we're scientists, because we're scientists in the room, we might want to evaluate this critically. So let's see what we can do with this. So if we want to evaluate whether this makes any sense or what sense to make out of it, one question we might ask is, are there evidence-based recommendations around cardiac risk? That would include, for example, whether you should do anything at all for someone who comes in with back pain. But if you are going to do something, are there some recommendations around this? Maybe there are, maybe there aren't. Even outside of formal guidelines or recommendations, what is the state of the evidence? Is there evidence for going beyond available guidelines? And either way, what's the potential impact on the patient for these kinds of things? Now I have to pause and say the evidence base around lab testing is often a mixed bag. So in the therapeutic world, if we were selling drugs or we were selling medical devices, we would have to generate fairly sizable evidence bases just for regulatory purposes to submit to the FDA to get our devices or our drugs approved. Now, you can make lots of arguments about whether that's complete, whether it's representative, whether it's enough or not, but at least it's something. To get a lab test on the market, you have to prove to the satisfaction of CLIA that your procedure is analytically reliable, and there has to be at least some plausible connection between that and something that might be of clinical interest. And then you can have your lab test on the market, and that's basically what's required. And let's face it, for a lot of lab tests that get out there, that's the extent of the evidence base. Something that assesses the analytic validity. But clinical impact, that doesn't get measured unless someone wants to go back after the fact and attempt something, which tends not to get done. There's a journal out there called Evidence-Based Medicine. It's part of the BMJ group. I look at the table of contents every month. I get it emailed to me just because I'm curious, what is it? It's one of these quasi-journals that republish papers that have occurred in other journals. So it's sort of a summary kind of a collection on things they consider to be evidence-based medicine. December 2013, table of contents had 15 reprints on therapeutics, 1 on diagnosis, 2 on prognosis, except that the prognosis ones were really therapeutics papers. Etiology and harm, 9 articles, but most of those were actually really therapeutics papers under another name, and then 1 on quality improvement. So, you know, even among the evidence-based medicine, you know, folks that do a lot of these hardcore kinds of publications, most of the attention's on therapeutics, very little on diagnostics. And although I can't say this definitively, it may well be that you just don't have as much to work with in the diagnostics world because the evidence bases are not getting created for regulatory purposes, so there's not a lot out there. So if you want hardcore evidence-based medicine kind of medicine, and if you held yourself to the standard that we're not going to order any lab tests unless there's guideline level evidence or grade A level evidence, we wouldn't be ordering a whole lot of lab tests, and then that wouldn't be very satisfactory either. So what are we going to do? Okay, so back to the original story. Again, it started out back pain, but it was really a question about cardiac risk screening. How do you measure cardiac risk in an asymptomatic patient? It turns out there's guideline level advice on this one because cardiac risk screening is a common enough problem that smart people have sat down in a room and formed committees and published guidelines on this. The U.S. Preventive Services Task Force you know, is a widely trusted source of this kind of information. What do they say? Well, they've studied this, they've read lots of articles, and they said, everyone beyond a certain age needs to get their cholesterol checked. That's going to include a total and an LDL, an HDL, and you plug your cholesterol into a formula along with your age, sex, and your blood pressure, and whether you're a smoker, and there are models out there that will predict your risk of an event in the next 10 years. And U.S. Preventive Services Task Force says this is what makes sense on a population level. They also go further and they say, in principle, you can measure things like high sensitivity CRP and homocysteine, and you can go way out there and measure things like ankle brachial index and your white count and your carotid intima thickness. There's also this thing called cardiac CT that's really expensive. And full disclosure, my brother's an electrical engineer for GE, and he designs these cardiac CTs. But U.S. Preventive Services Task Force says, you know what, on a population basis, it just doesn't make sense. It may have niche applications, but for a population asymptomatic individual, it just doesn't make sense. It's certainly not cost effective. So that's where they are. Okay, so maybe we're not going to hold ourselves to that standard. Maybe let's say that maybe the clinician should have some judgment and be able to do things and not be driven by USPSTF. How much potential benefit might there be to ordering things beyond a total cholesterol? Well, this has been studied a lot too. And there have been some really interesting articles in some big name journals. This one's from JAMA. What they did here, these are ROC curves, and they're measuring sensitivity and specificity of essentially different diagnostic algorithms for predicting cardiac events. The one on the left is specifically incident coronary heart disease. The one on the right is incident cardiovascular disease. So just doing slightly different definitions, but basically we're talking cardiac events here. And those of you familiar with ROC curves will recognize that anything that falls along the diagonal line from the lower left-hand corner to the upper left-hand corner is like flipping a weighted coin, and so it's no better than chance. And it turns out that the Framingham risk score is not a fantastic predictor of your near-term cardiac, or actually this is, I think it was 10-year cardiac risk. But it turns out the Framingham score, which is your blood pressure and your cholesterol and age and sex, is not a terribly great predictor because on the ROC curve, it's this blue line that is just a little bit better in terms of sensitivity and specificity than just predicting based on chance. It is better, and so it's recommended that you get your cholesterol checked, but it's not a ton better, so keep your expectations modest. But what's interesting is if you add in a whole bunch of other stuff, like high sensitivity CRP, you don't budge the ROC curve. So why are we doing high sensitivity CRPs on everyone? I may get myself in trouble for saying this, but I think it's because there's a Harvard professor that has a patent on the application of that test in cardiac disease who goes out around giving an awful lot of talks, and so we run a lot of these in our laboratories. Turns out the only one of these that really budges the ROC curve is this black line up here, which again is sort of modest, but it is an improvement. It turns out that's the cardiac CT. So cardiac CT will give you some added information on top of lab testing, but it's a lot of radiation, and it's really expensive, and again, it just doesn't make sense to do as a preventive care kind of thing. I mean, do you really want to take a whole bunch of healthy people and expose them to all that radiation when it's just not rational? So anyway, so that's the story. And yet, in spite of this, you have a lot of primary care doctors who are perfectly willing to fill out a lab slip for a $5,000 panel full of 30 different markers that no one has ever provided any evidence to say it's better than just getting your total cholesterol and LDL. Interesting state of affairs. Okay, so in our quest for clinical value, the only way this is going to work is if we hold up clinical needs as our goal here. And too much of technologic advancement in healthcare historically has been chasing after either technology for its own sexy state or a billing opportunity. Gee, there's a CPT code here, and there's this technology that I think we could bill for this, so let's offer it in our lab. A lot of things like that have happened historically. And if we're really about clinical value, then we have to hold that up. And the difficulty is measuring the clinical value. Anyway, if we're going to measure clinical value, though, it gets to an intermediate problem, which is this problem of figuring out how doctors turn data into decisions. The problem on this is actually a sort of a sticky one. If we were producing therapeutics, it would be much more straightforward to measure outcomes. So if we're designing hip joints, then we can design clinical studies that measure symptoms and sort of physical abilities and things in ways that we can measure the outcome of the hip joint. What if you've just invented a new cardiac risk marker? Well, you can publish whether it's correlated with cardiac risk, but that doesn't mean that measuring it is actually going to help the patient. Because to help the patient, there has to be a therapy in the middle of it that's different because of the test, and then the therapy has to lead to benefit to the patient. And that indirect relationship is such that it's very hard to measure. And another way of putting it is that in between the accuracy of the test and the benefit to the patient sits this big black box in the middle, and the black box is called how doctors turn data into decisions. So quantifying that is virtually impossible, but at least let's talk for a few minutes in a subjective kind of a way of what that black box might look like. Because then if we at least have maybe a subjective understanding, maybe we can do something with it. So how do doctors turn data into decisions? This is a study that I really like, and I have to be upfront with you that it's a very small scale, very old study. So I'm using it for illustration, not because it's an incredibly powerful study from a scientific perspective, but I just love the elegance in this one. There's an informatics guy at Utah that showed this about 15 years ago in a presentation, and I got really excited about it. So this is a story of two rheumatologists in 1983 that volunteered to participate in a little study. As rheumatologists, they are in the business of assessing rheumatoid arthritis severity. So you think of a patient with rheumatoid arthritis walks in the door for a follow-up visit. What's the diagnostic problem in front of the rheumatologist? It's figuring out, is the disease getting better or worse? Because you need to know, do you dial the medication up or down or switch medications? So assessing severity of the disease is the diagnostic problem in this case. It's not, do they have rheumatoid arthritis or not? It's, is it getting worse or not? So, but it's a very practical bread and butter kind of thing that goes on every day in rheumatologists' office across the country. So I took these two rheumatologists and they set up this artificial sort of a study where they handed them data on a whole bunch of fake patients. I think they were real patients that were just de-identified. And on each of these patients, they said, okay, we'll give you 5 potential pieces of information. And we want to know, how do you integrate those 5 pieces of information for your decision? Straightforward question. So the 5 pieces of information, articular index was one. I don't remember exactly how that was defined, but it was some quantitative assessment of how well the joints moved. Functional capacity was a different kind of assessment. pain was probably just one of these 1 to 10, how are you feeling kind of a pain score. Early morning stiffness was number of minutes before the patient felt like they were loosened up in the morning. So, is it 60 minutes? Is it 90 minutes? And then finally, there was a global assessment instrument based on a patient symptom survey. So they gave the rheumatologist these 5 different numbers on every patient, and they asked the rheumatologist, how much weight are you going to put on each of the numbers? And rheumatologist on the left said, I trust the articular index the most, so I'm going to put 35% of the weight of my decision on that. And I trust early morning stiffness the second most, so I'm going to put 30% of the weight of my decision on that, and so on down the line. And the rheumatologist on the right-hand side said that he trusted global assessment the most, and so would put the most weight on that. But interestingly, both of these rheumatologists, if you look at the bar graphs, both of them indicated that they would use all 5 data items in a relatively balanced way. Even though they'd weight some a little higher than others, they both suggested that they expected that they would weigh them in relatively balanced ways. So the next part of the study was they gave them the faked, the dummied up patient information and made them put a score on each one in terms of intensity, and then put it into a regression formula to back calculate how much weight they were really putting on each of these. Following me so far? And this is what it showed. So they were both correct in the sense of identifying which factor they were putting the most weight on. But that was the only thing they were correct about. Because they put, each of them put almost all of their weight on the one factor that they trusted the most. Is this unusual, or is this representative of what typically goes on in medicine? Well, again, this one little study isn't enough for me to argue scientifically that this is typical, but think about it from another perspective. As human beings, we evolved from earlier primates, and our brains evolved based on our ability to survive in a prehistoric age. What kinds of decision-making would have been required of the ancestors that we had that would have determined survival? Probably not complex Bayesian decision-making. Probably something more along the lines of immediate heuristic seat-of-the-pants decision-making. Your ability to decide when you're holding a spear and there's a mammoth coming at you, your ability to decide, do I run or fight, that's a quick, immediate, heuristic kind of a situation. It's not a long-term reasoned kind of a thing. Actually, psychologists these days split up decision-making into sort of slow and fast. There's a popular book out there right now called, I think, Slow and Fast Thinking, that suggesting we actually have 2 different parts of our brains. One dedicated to sort of contemplative, slower, integrative kind of thinking, the other, snap judgments. But in a modern clinical setting, let's face it, snap judgments, heuristics are a heavy portion of everyday clinical actions. And snap judgments are going to be based on the 1 or 2 data items that jump out the most. So if this is representative, it would suggest that what doctors really need is just the most useful data and strip out all of the rest because they're not going to use it anyway. Again, can't prove that based on 1 2-person study from 1983, but it seems to make sense. Here's another one. This was a study I encountered a little under a year ago that I think is sort of fun. It's not from a medical publication. You can actually get this one from CIA.gov because it's a little unpublished study that was referenced in basically an online book on intelligence analysis. So it turns out that the kinds of decision-making required of CIA analysts has quite a bit of overlap with the kinds of decision-making that doctors have. It's not perfect overlap, but you're basically taking lots of pieces of ambiguous, sometimes more accurate than others, data and trying to integrate it all into a conclusion. So from that perspective, it's a similar domain. So here's the study, and it was on Horserace Handicappers. I don't have a lot of experience with horse races, but the basic setup, presumably, is that you've got, I don't know how many horses in a race, but some number of horses in a race. And if you're betting on the horses, then there's some number of pieces of data that you might have available to you. You might know an individual horse's win-loss record. You might know the jockey's win-loss record. You might know whether the horse's wins were on a similar track surface, or whether the jockey's wins were on a similar track surface, or a similar length of race, age of the horse. So there are a lot of different data items that could go into this, and there are professionals at this that work as handicappers. So they took a bunch of these professionals that knew what they were doing, and they came up with 40 different data items that might let them predict the winner of a horse race. And they started with the 5 that seemed to be the most useful, and they gave them the subject handicappers each five data items for each of a whole bunch of races. Now these were actual races, they just de-identified them to change the horses' names so that they wouldn't recognize them. So professional handicappers with 5 pieces of diagnostic data each for each race, and asked them to predict the winner. And so that's this point right here on the left. And then they asked them, how confident are you of your prediction? So they were about 17% accurate in picking the winner, and they thought that they would be about 19% accurate. So a couple observations. Number one, clearly horse race betting is not a 100% kind of thing. There's enough variability and randomness in this that even the professionals are only going to be accurate less than 20% of the time. Presumably the non-professionals would be even less accurate than that, which is why it makes it interesting to even bet on with horse race. But what I find interesting was that these experts, because they were experts, were actually almost spot on in predicting how accurate they were. They knew that they weren't 100% accurate. Now, why is this important as a professional gambler? Because as a professional gambler, most of the game is not becoming more accurate picking the winner, because you hit a sort of point of no return where you're not going to be any more accurate than the next guy over. The important thing about being successful as a professional bettor is being really good at hedging your bets appropriately. A simple example would be if you put all your money on the first bet, then 4 times out of 5 you're going to lose it all and then you're all done. So professional gamblers are really, really nuanced at hedging their bets. Is this any different from clinical medicine? Patient walks in, they've got chest pain, so top of your differential might be something cardiac going on. But how likely is that? This is not a black and white situation. What are the alternative possibilities? How do you weigh those? Maybe an MI is only the 5% probability threshold, but what's your threshold for admitting them to the cath lab? So it's assessing accuracy that turns out to be one of the most nuanced and complicated issues of clinical medicine, not simply getting the most likely thing at the top of your differential list. It's knowing having a good sense of the probabilities is the important thing. So anyway, so back to horse race handicappers. At the 5 data item part, they were pretty good at knowing how accurate they were. If you went up to 10 or 20 or 40 data points, their accuracy didn't go up. Is that surprising? Probably not. Number one, the first study would suggest that as humans, we can't integrate more than 5 data points anyway. And secondly, there's a good chance that all those data points were so auto-correlated that maybe they weren't even adding useful information. So I don't think it's surprising that their accuracy never went up when you went beyond the first 5 useful points. But what was interesting about this is that their confidence went up. And these are experts. These are people that bet on horses professionally for a living. And due to some unconscious process going on, they got way overconfident when faced with more data than they could handle, which again, that's dangerous. What's number one factor going into misdiagnosis? It's usually overconfidence in the diagnostic pathway that you take. You start treating the guy for an MI, turns out they've ruptured an aortic aneurysm. You couldn't necessarily have known that up front, but if you weren't so overconfident about the MI, you would have kept your differential open and kept open to the possibility and saved the patient. So it's not, again, diagnosis is not a black and white thing, and confidence turns out to be a really important thing. And the scary thing about this is if horse race handicappers become overconfident at 40 data points, what about all the doctors here at your medical center that you're flooding with hundreds of lab results every day? What's going on? I don't know, but it makes you stop and think a little bit. So take-home points, excess testing beyond beyond a certain point, adding on more testing is probably not adding a lot of information value, but it may be actually detracting from doctors' ability to make appropriate judgments. Okay, so that's the argument to say that we need to be more thoughtful about, as a healthcare system, about how we deal with diagnostic data, and not simply have the simplistic idea that more is always better. So let me shift gears a little bit and say, well, what can we do about it? Because historically, let's face it, laboratories historically have not been in the position of being either expected or given the authority to manage how doctors use tests. But there are some things that can be done, and there's some examples of places that are doing some interesting things out there. Okay, a few words about governance. So this is sort of assuming that there can be governance of test ordering. Some people would argue, particularly some clinicians that don't want anyone watching over their activities, some would argue that there's no such thing as clinical governance. I would argue that prior to 1980, that would be the majority view. In the year 2014, let's face it, there's going to be clinical governance of everything that we do. So get over that and we'll move on, and let's just figure out how to do the governance. The example I thought about sometimes, and I don't know why this even surprises us in clinical medicine. Let's just imagine for a moment that we all quit our jobs and joined together and decided to start a car manufacturing plant, and we're going to compete against Toyota for a while. And maybe our approach to a car manufacturing plant is we're going to hire away a whole bunch of people from the Toyota plant that have expertise and know what they're doing. And we're going to hire them, and once we've hired them, we'll give them a badge, and we'll tell them to go in the plant, and we'll tell them to figure out what they need to do, and we're all going to go to lunch, and then we'll come back a year later and see how good the cars are that came out. And that's, I think, to some extent what goes on in clinical medicine. The I know this is unfair, but largely the clinical activities in medicine are managed only by the individual doing them and not by a larger measurement process or a structure that ensures quality. We tend to add on quality improvement as an afterthought here and there, but let's face it, our hospitals for the most part rely on individual doctors to do most of the decision making, and there's a lot of trust involved, and you could never get away with that in anything outside of something like medicine or law. So if we're going to have governance, what should it look like? This is a political opinion statement on my part, but I'll explain it. My political opinion is that if you're going to do governance of something clinical, the more of that activity you can pack close to the point of care, the better. The more you can pack close to the point of care, the better that ends up being. The more efficient it ends up being, but also the more effective it ends up being. So what do I mean by this? You go back to, say, the 1970s, and there was essentially no governance, no oversight of doctors' activities. Doctors were independent contractors. It was trusted that they knew what they were doing. No one was second-guessing their activities. You get into the 1990s, and suddenly the costs are getting high enough that people are getting worried about doctors doing stuff in too expensive ways. And so regulation is not the right word. Oversight started to come in. And where did that oversight come? Came mostly from the payers. So this was the managed care era. And suddenly you've got things like prior authorization. You've got doctors having to call and justify what they're doing to a nurse who's working for the insurance company. It's not terribly efficient because you're trying to manage an activity by taking the manager who's not only not physically there, but they don't know anything about the patient, they don't know anything about the environment, they don't know anything else. So again, back to our car manufacturing environment. Let's take our car manufacturing plant that's obviously not doing very well, and we're going to improve it because we're going to get a lot of smart managers. We're going to hire them from Toyota. In fact, they're going to live in Japan because they know what they're doing. And once a month, they're going to call in and double check a few quality measures. And every time the people in our manufacturing plant do certain things, they're going to have to get prior authorization by spending a half hour trying to track down someone in Japan to get permission for what they're doing. This doesn't sound very efficient, and in fact, it's not. And trying to manage clinical activities, which is a very nuanced, expertise-based kind of a thing, by someone that's another state over, it's sort of ridiculous, and yet that's what happened in the managed care era. And this happens at the regulatory level too. Every time CMS creates a new quality measure, The quality measure takes 3 years to vet, to politically test out, make sure it's acceptable to everyone. Then they come up with a whole bunch of definitions, and then you report it. By the time you're reporting your quality measure, the science is 3 years on, and it's actually the wrong measure, and it's complete. And you're treating the patients. You're having to decide between treating the patient appropriately and treating the patient to optimize the quality measure. Regulatory doesn't work. Payer doesn't work to manage clinical care. Managing at the physician group level, department level, if you're running a car manufacturing plant, there's a foreman who's right on the factory floor. Well, in our internal medicine departments, we've got department chairs and chiefs. They're right there in the hospital. Why aren't they playing an oversight role in making sure that we have consistent quality of care? That's where the authority ought to be. So anyway, again, it's sort of a political statement, but I think in our healthcare system, we haven't figured out how to do proper governance of clinical care, and that applies to diagnostics as well. Okay, a couple examples of places that I've seen that have done some interesting things. None of these are necessarily where they could be in 10 years, and I don't know exactly what's going on at the University of Washington, so some of this, I don't know whether any of this is any better than what you've done here, but just a couple different ideas that I've seen that I think are interesting. One was University of Rochester. This was an environment for 5 years ago. They were feeling a lot of pain in expensive send-out testing. It's an academic center. Sort of the prototypical situation would be that the house staff seeing some new patients with potentially some, entertaining some zebra diagnoses, aren't sure they can 100% rule out all of those zebras. They don't want to get yelled at on rounds the next morning because they know their attending is going to ask them about those particular zebras. So house staff try and cover their bases by ordering lots of expensive, obscure tests that the attending, had they been there, would have said, don't waste your time on. But the attending's not there till the next morning, so they just place the orders. Some of which turn out to be genetic tests that take 3 weeks to get back, and the patient's going to get discharged 2 days later anyway. But again, the residents don't want to get yelled at. So that was sort of the problem that led them into this. And they decided to create a formal laboratory diagnostic committee. The ideas were developed in the laboratory by the pathology leadership, but they made a decision early on that they felt that politically this would play out a lot better if internal medicine was the fall guy. So they got the chair of medicine to chair the committee, and he was very willing to. And they got key subspecialist physicians in internal medicine, surgery, and others to be members on the committee and to develop rules for which obscure tests ought to be regulated, and created a formula. Actually, the first thing they did, which was probably the most practical, was any send-out test over a certain cost required a co-signature from the attending to place the order. Simple intervention, but it got rid of the problem of my attending might want this, so I better order it, because it translated into my attending is going to have to actually co-sign it and represent that they really want it. And part of that co-signature was the attending attesting that they anticipated that this would benefit the inpatient stay. It would change their decision-making during the inpatient stay, because this is for inpatients. So University of Rochester, I don't know what your send-out expense graph would look like if you plotted over time. I'm guessing there may be someone in the room that knows the answer to that. I'll tell you that University of Rochester's was going up until they started the committee, and it's been flat since then. It's actually dropped a little bit since then. So it works for them. University of Michigan, there was a nice little article on AJCP just about a year ago talking about their experiences over the last 5 years. I encourage you to read the article if you're interested in it. The article, again, they chose to have this chaired by internal medicine. But the article, a lot of the article is about the cultural factors at play, and the way that they tried to keep the committee true to the academic culture of the institution. So the committee did a lot of things around education and literature review, and to do things in a cultural way that it would be well accepted. And their conclusion was that they thought it was a success. And then University of Iowa had some conversations with a pathologist there, the name of Matt Krasowski, who's been involved in their committee. Again, very similar to Rochester and Michigan. One of the things different about Iowa, I believe that they've been a little bit more open than some of the others about non-physician leadership and participation in this. So they were very active in including genetic counselors, for example, lab management and others, to make more of a broad-based kind of thing. But again, very, very similar. The other comments from Iowa was that they were, actually I think I have this in my next slide. Number one, there are a lot of clinical constituencies in a hospital. It's not going to be realistic to include everyone, but anyone that's willing to participate represents an opportunity. So if you think of all the different subspecialties as a constituency, different parts of nursing, different parts of operations, you've got way more constituencies than you can get on a, maybe more stakeholders if you look at it that way, than you can get on a single committee. And some of those are probably going to be more enthusiastic about this than others, and it's going to be based on personality. So, you know, your chair of surgery may hate this, but your chair of anesthesia may love this, or vice versa. But by engaging the ones that are actually open and interested in this, just being opportunistic, each of these institutions has gotten a lot of mileage out of it. So you create a committee, and they review laboratory tests, and they make judgments. In an academic center in particular, but really it should be this way anywhere, that we stay true to our roots. We want everything we do to be evidence-based. So back to the discussion at the beginning, that's a difficult one because the evidence base is variable. If we only make decisions based on guideline level communications, then we're not going to be doing a whole lot of lab testing because the vast majority of lab testing in this country doesn't actually, there aren't applicable guidelines out there. But we do have guidelines for some things. We have local expert opinion available. And then finally, benchmarks. Okay, so the point I wanted to make broadly on this, because the evidence base isn't perfect, you can't expect perfection. And the standard that I think makes sense is if it's locally credible in terms of your physician base, that's probably good enough to get started with. Let's talk benchmarking for a minute, though. So benchmarking, this is one that I learned about at Dartmouth. Benchmarking is simply comparing what you do with what peers in other geographic locations might be doing. On the surface, you might think, well, who cares whether I'm doing the same thing as people elsewhere in the country? The beauty of benchmarking, though, is a couple-fold. First of all, it's a lot easier to get benchmark data on comparing your volumes of things to other people's volumes of things than it is to measure normative quality measurements. Those get more difficult to measure, more complicated. Benchmarking is just easier. Second, and it's much more widely available. Secondly, benchmarking takes you as the measurer out of the position of making the judgment. So again, when I was at Dartmouth, I think Dr. Obashan shared data from the Northern New England cardiac surgery group where they compared blood use during cardiac surgery across different hospitals. Now, if the research group had come out and said, doctors X, Y, and Z all use too much blood, that would have been politically uncomfortable. It would have triggered arguments. No, I don't use too much blood, blah, blah, blah. They didn't try to do that. They just measured how much blood was used by all the different surgeons at all the institutions, and then they produced a graph, and that was the end. And it was up to the surgeons to make sense of it. So it put the burden back on the clinical group that should have been paying attention to this in the first place, and it led to some pretty serious behavioral change on the part of those cardiac surgeons. So again, the beauty of benchmarking is it takes you as the lab or whoever you happen to be out of the position of making judgments and simply in the position of producing transparency. So this is from the Dartmouth Atlas. There are lots of cool maps on there. This happens to be hospital discharges per 1,000 Medicare enrollees. Again, it's the sort of thing you can do. They're not saying whether one part of the country hospitalizes too much or too little. They're just saying this is how much they do. But it's very interesting that the eastern half of the US seems to hospitalize people a lot more than around Washington or Utah. I don't know what it means, but it might mean that there's a lot of over-hospitalization going on in the eastern half of the US. So benchmarking is useful. I don't have time to go through all of these, but I'll give you one benchmark example from my own experience in the laboratory. Again, just to illustrate, because these opportunities are out there all over the place. At ARUP, we're a reference laboratory, so we do commercial reference lab testing for hundreds of hospitals around the country. And in the context of those relationships, we periodically analyze the utilization of different tests that are sent to us by different hospitals and share that with the hospitals. This was a hospital in the southeastern portion of the US, and in the course of one of these routine reviews, we happened to notice an outlier. The outlier was whole blood drug abuse testing. They were spending about $70,000 a year on doing drug abuse testing on whole blood. It caught our eye because it's a very unusual thing to do. Drug abuse screens we normally do on urine. And there may be an occasional reason to do it on whole blood, but $70,000 a year. And we knew it was an outlier because of 95% of our national volume. This hospital is like the only reason we even kept this test online. So we called them up and we said, this is sort of curious and interesting, and we're wanted to bring it to your attention, and we're just really curious why you're doing it. Is there something we should learn for this? The clinical chemist at the other end, who's a very smart guy, comes to ACLIPS meetings, for those of you involved in ACLIPS. At the other end said, I had no idea. Now, should we criticize him for having no idea? No, he's got thousands of tests on his laboratory's menu that he's trying to pay attention to. How is he supposed to know that this one was an outlier if there wasn't some way of bringing it to his attention? So he had no idea he was an outlier. But he agreed it sounded really curious. So he made a couple phone calls. He looked in their database, figured out who's ordering it, made some phone calls. It turned out that the story on this was actually a quality improvement effort gone a little bit awry. The hospital, probably their nursing department, had asked all the different clinical departments to standardize their standard operating procedures. And of the transplant groups, the first group to do it was the largest one, which is the kidney transplant group. And it turned out that the kidney transplant group was doing a certain amount of drug abuse screening on their patients, which makes clinical sense because renal failure patients have a higher rate of drug abuse, and you don't want to transplant someone that's using a lot of cocaine on the side or whatever, I don't know. But so there was a reason behind some of this testing, but that was only a little bit of testing. What really happened here was when everyone was asked to develop standard operating procedures, the bone marrow transplant group and the heart transplant group and all these other transplant groups copied and pasted from the kidney transplant group's SOP. And the next thing you know, they're ordering the wrong lab test, and no one knew. So there are a lot of things like this that simple benchmarking will bring out into the light, and you can make real improvements. I have to highlight this one because this is Brian Schertz's project when he was a resident with us. This one's an example not of benchmarking, but of using a guideline. So there are a few sort of high volume, high impact areas of laboratory medicine where there are guidelines, and cervical cancer screening happens to be one of them. Now, the old cervical cancer screening guidelines were easy. Annual exam with pap smear. That's easy to follow for an OB or a family physician. Annual exam with pap smear. You finish the pap smear, tell the patient, come back in a year, we'll do it again. That's an easy algorithm. I would consider it pretty cookbook medicine because it's not patient specific or anything else, but it sure is easy to follow, and it got implemented, and we had really high compliance across the country. Well, fast forward to 2014, or even at the time of this study, it says in press, we actually did get this published. I didn't update my slide. Back to the late, about 2006-ish, the guideline had updated. Now you've got HPV testing, and now the guideline actually is pretty complicated because it's based on age and previous pap smear results and previous HPV results. And it's like a one-page explanation that you have to sort of go through and see where does my patient fit in. So Brian here took a look at the data to see if we could see any patterns in our HPV results that would give us clues as to whether people were following the old way of doing things or the new way of doing things. And I wasn't sure going into this if we'd be able to tease any patterns out, but Brian was willing to give it a try. So the first thing we looked at was age, because that was easy to analyze. The old guideline just said annual exam. The new guideline says age matters. If you're over 30, you do this algorithm. 21 to 30, you should do it as a reflex. Below 21, no testing at all. Repeat, no testing at all. Either pap smear or HPV is potentially harmful with the patient. Don't do it. If it accidentally gets ordered, ignore the results. I mean, it was actually that strongly worded. So we took a look. The blue line and the x-axis are years, so it goes from 2003 to 2009. The blue line are ARUP's national volume of HPV testing on patients over 30, and it went up over time as HPV became more popular. No surprise. The green line was patients 21 to 30, didn't go up as steeply. Again, that's probably reasonable. That group has less to benefit. The red line I guess the good news is that the red line as a proportion of the total got smaller. So these are the patients under 21. So by 2009, only 4% of our patients were under 21. The bad news is none of those 4% should have gotten the test in the first place. Because the last thing you want to do is take an 18-year-old with HPV that's going to go away in the next year, and maybe they'll get a colposcopy, a biopsy. You don't want to be cutting away cervix in a young woman who may have kids in the future and needs an intact cervix to avoid preterm labor. There are lots of reasons why this is bad medical care, and yet it goes on all the time. This slide was looking at time interval. Most of the women this is just women over 30. If you're over 30 and you have a negative HPV result, most of the time you're going to have a negative PAP2, and you don't need to come back for at least 3 years, probably longer than that. So Brian took a look. This is a histogram of number of months till you returned. The peak is at 12 months. So you put these things together. As of 2009, we've got this great guideline for cervical cancer screening that's no longer cookie cutter. Now it's patient specific. Some people call that personalized medicine. As of 2009 nationally, did we see evidence that people were following personalized medicine? No, we saw evidence that people were following the cookie cutter. So all of the doctors and clinicians out there that rail against guidelines to say, oh, that's cookie cutter, I need to do personalized instead, it's actually flipped. So anyway, it's just food for thought. But my point is there's lots of opportunity out there. Lab tests tend to get used in lots of different ways that sometimes good for the patient, but not always good for the patient. There's a need for someone to step in and do oversight, quality measurement on whether lab tests are being used effectively, because it's just not happening today. And I think folks in laboratory medicine might be well positioned to play roles like this. And I'm going to stop there because I've gone over my time a little bit, but we could take a question or two.
Time for one or two questions.
Yes.
Where do you see payers heading in the future in terms of looking at indications for testing and procedures and making reimbursement decisions based on that?
Yeah. So this gets the realm of personal opinion on my part, because that's a complicated one. Oh, sorry, I'm supposed to repeat the question. Thank you. So the question. Now I'm going to misword it, but the role of looking at indications ahead of time to evaluate the appropriateness of test orders and whether reimbursement decisions should be based on that. Am I close? Try again.
I'll reword it.
Yeah.
So retrospectively, in the future, when people retrospectively looking at test and blood product and drug and whatever utilization, are payers going to be increasingly scrutinising what they consider appropriate versus not and making reimbursement decisions based on that?
Right. Okay. So
certainly a focus of JCO moving forward to look at the appropriateness of blood transfusion and of test utilization.
Okay, so a couple of questions in there, but you're talking about looking retrospectively over lab testing as well as blood transfusion to look for appropriateness, and then you're also asking about tying reimbursement decisions to that. So in my opinion, this gets back to a management problem. What's the most both effective and efficient way to manage and improve the quality of laboratory decisions? So some sort of retrospective review makes a ton of sense. To be doing a lot of clinical activities and not have anyone looking at that or trying to measure that is problematic. So there's definitely going to be a role for looking back and trying to evaluate whether something was done well or not. Whether or not reimbursement decisions should be tied to that gets really tricky, because as soon as you tie a reimbursement decision to appropriateness, effectively the reimbursing agency is acting as the manager, and suddenly you as the actor, as the physician, you're responding to them rather than to the patient and the clinical needs. So suddenly, so even though the insurance companies say we're not practicing medicine, everyone knows that that tying reimbursement decisions to appropriateness is a form of practicing medicine. Now, I'm not saying that insurance companies shouldn't have some role in that, but it should not be a detail level, item by item review, because they're not in a position to do it well, is the bottom line. Who is in a position to do it well? Someone who's clinically trained, who's right there near the person making the decision, would be in a position to do it well. So I think insurance companies need to figure out a different role that's more suited to their capabilities. Data transparency is certainly a good one. But my guess is that we'll move to more capitated care anyway. In some ways, will prevent this problem because suddenly the folks making the decisions will be close to the point of care. Now, the problem with capitated care is that if you impose capitated care today, the vast majority of clinical enterprises have no management system in place at all to do any sort of assessment. And so it's a step backwards, but that's why I think healthcare organizations need to start developing the systems, including the laboratory. Yes, question?
You know, this was actually a really great talk. So one of the, it seems to me like the bulk of your conversation actually says that diagnostic management teams become the way that laboratorians can demonstrate their value to patient care and patient diagnosis. Is this the only way that we can do it? The only way that we can restructure the system so that you can take people knowledgeable about the laboratory, knowledgeable about the lab tests, and bring all of that expertise right there to the bedside?
Yeah. Okay. So the question is about diagnostic management teams and their role in producing better diagnostic processes, and whether that's the best or the only way of doing this. So I like that question. Those of you who may not be familiar with Mike LaPosada's work down at Vanderbilt, I encourage you to take a look. He uses this term diagnostic management team, and they've set up in a number of focused areas team-based review. So think about a real-time tumor board. Normally, tumor boards meet once a week. You talk about the problematic patients. But what if you could take tumor board and make it more real time? So if tumor board met every morning and reviewed every single case, then suddenly you could deal with more day-to-day kinds of issues rather than just the purely big picture kinds of issues, and you could have a bigger impact. So it's a very intriguing idea, and they've applied it to hematopathology, coag, and I think a couple other areas. So I actually think it's a really intriguing idea. And at Vanderbilt, the laboratory has played the sort of the convening role to bring people together to do these activities. And it's great for pathology training and fellowship. It's great for pathologists as well to get into that role. So I'm very intrigued by that. I think there's a lot of promise, but I wouldn't say that that's the only possibility. I'm just hoping that people actually come up with any ways at all to manage diagnostic activities.